Well, I wasn't sure if I should actually thank him here because he asked me to talk about hospital policies after lunch, which might put everybody to sleep. So I decided to take a little spin on that and look at some of the differences and basically how can we deal with hospital policies and administrators and actually make it work in your trauma practice. Because I think that there's some things you can learn. And how do I know about this? Well, I was the associate physician in chief of the Kaiser Medical Center in Oakland for quite a while. Then came over and became vice president of perioperative services at UCSF, and then took a similar role at Memorial Sloan Kettering in New York. After all that, well, I've decided to come back to UCSF as a total joint surgeon. That tells you how much I really enjoyed all the administration. So I'm back doing what I love. So you said I was coming from Sloan Kettering, but as of next week, I'll be from UCSF. So anyway, it's good. I want to talk a little bit about the different areas where we see policies, administrators, surgeons sort of colliding, if you will, or working or trying to work together, and how each one has real reasons as to why you may collide and why you may be able to work together to make it better. So when we're talking about sterile processing, patient safety, implant choice, documentation, and scheduling of OR cases, all of these areas have policies that are really critical to protect the patient, to protect the hospital, to protect you as a surgeon. And I think we need to work together to do these things well. Why? Well, these are some of the silos that we have. I think all of us have to recognize that these are management silos where we have a hospital manager managing these areas, and they may have, or actually do have, different reasons for being than you. And so you have to understand what their thought processes are in order to get things right for you. So you see OR nursing, floor nursing, they're actually two completely separate silos very often. Sterile processing, materials management, all of these things have different silos. And the managers, they're good people. They want to do good things, but they're primarily evaluated on being able to keep to budget and keeping their people happy. That's it, okay? So they don't necessarily do their jobs to make you happy, to make you efficient, or even to make the hospital efficient. They do have to pass the Joint Commission survey every few years, so they try to follow the rules as far as they can to get you through that. But what's interesting is they're really not responsible for revenue. They're really not responsible for profit. The only people in your hospital that are responsive to profit is the CEO or the COO, basically, because they worry about revenue at this lower level of administration. They don't look at cost, or they look just at cost, and they don't look at revenue. They rarely look at both together, and so it's actually interesting. So when you come to them and say, I want to be much more efficient, which might actually decrease the cost in the hospital and actually make them more profitable, a lot of them don't understand that because they don't ever put revenue and cost together. And that's very different than in most business environments. So I just want to make that point so when you think about it. The policies that come to be, I think number one, you should recognize they're derived by administrative leaders. They're rarely derived by physicians. And when physicians get involved, they sometimes do it for probably the wrong reasons. And I'll give you an example of what do I mean by that, the wrong reasons. I had one facility where I worked at where we were trying to make the conversion for patient safety to marking of the patients, in advance of surgery, and make sure that we do things right, that the academy has done for years. The neurosurgeons got involved because they didn't want to have to mark the patients in advance or even see the patients in advance before surgery. So they got an exemption if they used 3D imaging, like an Aero CT or something like that. And as it turns out, they always ordered the Aero CT. I don't know why, even though they weren't using it. They always ordered it, so they never had to mark their patients. Well, interestingly enough, in this particular facility, the reason we had to go to marking and everything else in the first place was because of a wrong side craniotomy. And then, of course, soon after I got there in the management role, there was another wrong-sided craniotomy. And it turns out that they were never marking the patients because they got involved in the policy process and tried to put a wrench into it, not for the right reasons, but because they didn't want to be hassled. So I just say that if you get involved in these things, try to make sure you're doing it for the right reason. And you can make things efficient, you can make things better, but don't do it for the wrong reason. Many of the policies can cause delays and inefficiencies. We all know that. I'm going to go through some scenarios that you as trauma surgeons sometimes run into. Maybe you don't, but I think you probably do, and I can explain both sides of things to show you sort of what the perspectives are. So, here's somebody who wants to bring in periarticular plates. You've got a distal femur fracture that looks pretty bad. You want periarticular plates. You want locking standard large frag. You want cables. Maybe you want cannulated screws, small frags just in case. And maybe you're going to throw in a distal femoral replacement set just in case. Okay, just because, hey, you got to be prepared for everything. A couple of things that you can get into here as far as policies. One policy might be at your facility, you have to have all the sets there 24 hours in advance or 48 hours in advance. So you might run into that problem. You might run into the problem that they don't allow you to flash, and nobody flashes anymore. When I first came into practice, there was a lot of flashing. You can get a set ready very quickly. Does anybody know how long it takes to get a tray cleaned and sterilized and ready? Truly, it takes 4 hours. It does not take 20 minutes. And a lot of the surgeons don't understand that. And so when you look to understand it, you see that if a tray is coming in from the outside, there's not a trust that it's been washed effectively. So you have to take it to the washer. And that doesn't mean just putting it in a machine. That means pulling out all the instrumentation, scrubbing it, and make sure that it's washed, really washed. That's even before it gets to sterilization. Then you got to put it back in, you got to wrap it, you got to sterilize it, you got to cool it, you got to bring it upstairs. That's a 4-hour process. I remember one night being called because a surgeon wanted to bring in, actually did bring in, 28 trays at midnight for a 7:30 case. Okay, and it was an elective total joint, and the director of sterile processing called me and said, I can't do this. And I think that when you think about that, they have a point. Do you know what I mean? You have to get your stuff there in a reasonable time frame, and otherwise you're going to have late starts, you're going to have upset OR staff. The other thing to remember that not all surgeons know is that if you bring a tray into the room with a patient, most hospital policies say that that tray needs to then be completely washed and sterilized again before it's used again, because it's come in contact with the patient. If you leave it outside the room, you don't have to do that. So if you're talking about this distal femoral replacement set that you never use, don't bring it into the room with the patient there. Leave it outside the room so you can bring it in quickly. And that has to do with your hospital policies, and it makes life a lot easier for you, and your OR staff and your sterilizing folks will be much happier, because the average cost to sterilize a tray is about $125. So if you're bringing in a lot of trays that are, quote, standby, and you're putting them in the room because you really feel they need to be there, that can be a problem. So really talk to folks about that and understand it. That's just one of the things that's a lesson. Here's another one. You want to start first thing in the morning, but anesthesia is working with the resident in the next room. I'm sure that never happens to any of you in a teaching situation, but it does happen, and you're going to catch a flight that day, and you say, oh my God, I'm not going to get done. And the hospital policy says the attending has to be there with the resident, et cetera, et cetera. Well, there are ways to work around this. You know that, with residents that's true, but in teaching situations, this is often applied to CRNAs also. Well, CRNAs can put the patient to sleep without an attending. So, you can change that policy perhaps if you work on it with anesthesia. And the other thing you can do is stagger your start times into different places. So it's something to talk to folks about and understand where it is and how you can do that. But there's a reason for it, because there can be problems with residents and they need to be taught just like everybody else. This is another one that comes up frequently, is they have space. You look, there's an empty operating room right next to you. You've got another couple of cases to do. Why can't you just flip into that operating room? We've got to remember that an operating room doesn't come with staff necessarily. And I think that's the biggest misconception that we have out there, is that it is a mandate from the administrators that they actually keep those operating rooms full. And if they're not full, they shouldn't staff them. So we've got to be a little bit careful about just assuming that an empty operating room is always staffed. So let's be careful about that. And when you're dealing with the policies as far as what things go on there, that can be an issue. This is another one, has to do with documentation. You forgot to date the consent. Pre-surgery is calling you. They want you to order a type-in screen for tibial rotting. You're in a critical research meeting and you can't leave. Just bring the damn patient in the room and I'll deal with it, right? I mean, I'm sure all of us have felt that from one time to another. And again, there's a reason for this. We got to make sure the consents are done appropriately. So just make sure you do them in advance. And the type-in screens, I know that in many places, nurses cannot write a verbal order. So you can't just tell them to do the damn type-in screen. You need to actually write it. So again, in talking to folks about it, you just have to be able to do this effectively. And this is one other thing that comes up frequently in trauma practices. It's Friday at noon, you have a hip fracture to schedule. The OR says, oh, I can't do it till past 11. You're like, I'm not spending the middle of the night doing this case. Let's schedule for 8 o'clock tomorrow morning. And they say, no, we don't schedule anything for 8 in the morning. You have to call back in the morning and put it back on the list, or whatever that is. And I think that that's a common thing. This is something where you can really sit down and negotiate. I know I negotiated very significantly at one point to say, hey, after 4 p.m. on a Friday, you should be able to schedule on a Saturday. You don't want to do it 2 or 3 days in advance because you get all these spine surgeons scheduling discs at 8 o'clock in the morning on Saturday morning, which I've seen. So the bottom line is there are compromises you can come to. You just got to sit down with your administrator and discuss it. I could go on and on. I could spend hours on this kind of thing. I had a number of other slides about sort of efficiencies and everything, but I'm going to skip over them. Let's go back one here just a second. How to succeed. Just remember what your administrators are accountable for. Always keep quality of care and service to patients at the top of your mind. Don't say you need to be more efficient, because your efficiency is not the same as hospital efficiency. You can run 2 rooms, and that's great. You, as a surgeon, are more efficient, but the hospital is not more efficient generally because they're not doing the same number of cases in each room as they would have if you were in one room. So, and it's hard to measure. So just be careful about saying that. And just the last slide I'm going to go on here is just to say the lessons. Administrators are really good people who care about patients and their care, but are truly motivated by budget, i.e. cost, and employee satisfaction, not your satisfaction as a surgeon. Policies are derived by good people, but they need good clinical input and honest clinical input. And negotiations should always be respectful, excuse me, and about what the patient needs. Thank you.